Um, I've been here on a little bit over 6 months in this new position, and I was 18 years in an academic institution, we were really very much early on the stroke race. So a lot of the times there were no guidelines, and we had to basically be part of the trials and everything. And being early, there are advantages because we were able to build a good referral and a good hub and spoke model. And then our telestroke model was very powerful, and we were able to survive on that for many years. But I have to say that more recently, in the last few years, as in Chicago, and if you look at the Midwest, there was at least 18 sites in Chicago that do endovascular. There are 5 universities. It's a very competitive market. And there's no question that I start seeing that if you didn't own the hospital, if you had only one hospital in your system, and all the feeder hospitals were basically a handshake, so you had a telestroke contract or something like that, the competition is such that every institution that is in town will develop programs like this, and all of a sudden, all your network is going to be challenged almost in every 3 months or every 6 months. I don't know if you know about this, but there are basically outreach teams that go and knock on everybody's door, and just like you build your first hub and spoke model, now there's, imagine around you, 4 or 5 different systems trying to do the same. So I think it's very challenging. I think the name of the game for us had to change from a hub and spoke type of situation to what's called the integrated comprehensive stroke center or system. So this is something that we also think likely Joint Commission DNV will move into, start evaluating us, not for the value that you have a comprehensive, a primary stroke center or a thrombectomy ready center, but they're going to evaluate us as a system. And so if you are able to show that if somebody reaches your hospital, it could be a primary stroke center, but belongs to the quality of the system that you have, the advantage of that is that they don't need to mobilize their ambulance too far out from because we have to be sensitive about other forms of trauma, other uses of EMS. So what we're trying to do is that once you deliver to our system, we have our internal transportation, and we'll then dispatch the patient in a more efficient way than could ever be done by anybody that is getting those patients in the field. So it's one model, it's one way to look at this. Of course, this is a tri-state, the region here we're talking about between Milwaukee to the southern part of our system. It's about 200 miles, and we have about 12 million people in this area. And so how do we do this? We call the next generation of stroke and cerebrovascular care. And we had great examples. Our Heart Institute is very powerful. So the number of STEMIs is the largest in the Midwest, as well as cardiothoracic surgery. But more importantly, something I didn't have before was we are the #1 trauma provider in the city. So our hospitals are very familiar with EMS. And as you know, Chicago or they have many regions. So each is a micro a micro environment that requires there has its own set of rules and guidelines. So it's not very easy to have a representation in every EMS region unless you have a system that you can be part of all those discussions. So, of course, what we see on the success of these models now, they are somewhat impacted, not only because we are getting better in treating stroke, but also because maybe there is the indications for treatment are refined and they're increasing. So that is increasing that number. So it's not that we are only doing better on increasing the patients that get access to TPA, but mechanical thrombectomy numbers are exploding. But of course, that number is moving. What we used to treat before now is a much larger percentage of the cases because of the trials we have done. So the projections are that we're still under treating, that we probably will increase as trials Dr. Filler showed us today. They will increase our indications. So clearly, this will be a growing participation of what we do and the impact of what we can do. So I felt that moving into this challenge of building a network that functions well as a network would be very important. So we looked in the city, there were 3 different networks, and this one in particular I thought was appealing because in Wisconsin, they have about 30% of the entire state is represented by Aurora, basically. And when they merged with Advocate, then we had in Chicago, in Illinois area, we had 2 comprehensive stroke centers, Christ and Lutheran, and then a number of primary stroke centers. But from here, 3 of them are mechanical thrombectomy ready, or thrombectomy ready. So we have in Chicago 5 centers that can deliver thrombectomy. 2 are comprehensive, and 3 are thrombectomy ready. In Wisconsin, we have 2 comprehensive stroke centers. So this is a little bit of our distribution. They actually are very well geographically, very well distributed because they're trauma position. So in these distances here, they are basically the trauma centers of that area. So we affiliated with that, the thrombectomy ready and comprehensive stroke center status. So we had to build a huge team. So we have 12 interventionalists in our team. So 12 folks that can do mechanical thrombectomy. And of course, and it's we have radiologists, neurologists, and neurosurgeons represented here. So it's a very large team. And you will start seeing these things, and this is obviously now a patient that's hitting when you say it's a primary stroke center and it's hard to control. The outcomes of our results will depend on the efficiency of where the patient starts on the system. And the coordination of that care, that's what I'm talking about. This is, within the first 6 months, I can sense a lot of things that we do better, but with a little bit of organization, we're already seeing those impacts. And I promise you, as the next year or next, probably, I'm thinking this will take a little more than that, but in a few, I will show you some of the results of this, but this is where we were going now as a concept. And I will show you that this is more or less also the size of the hospital, so you have an idea. You're talking about 600 beds, 750 beds, and then 300. So there's three hospitals that are 600 plus beds, and then the others are 300 to 400 beds. And the total hospitals, it's almost 30 hospitals in the whole network. So we have something unique, which is you have to prepare to a model of mothership, drip and ship, and then you have this issue of how can you capitalize on not using having the EMS, having to go to too far of a distance. How can you coordinate within the network a better delivery of care? So the first thing to open, we just opened this, it's called the Patient Command Center. So here we coordinate in one building, it's a standalone place that we have each hospital represented in a monitor with a bunch of, you see these monitors here, these are all folks on the telephone. So every patient line that calls to the center, we are able to see what is the closest hospital that has a bed available with the level of care the patient needs to go. So it's a way to coordinate the care in a network that it goes in 3 states. So it's a very important thing to start with, because it's a nightmare if each hospital is trying to coordinate all the transfers. They have no visibility of what's happening with their other hospitals within the network. So it's really key that you develop a standalone patient command center. Our EMS team is actually sitting there, and we have also now working on the internal transportation system too within the network. Of course, the conventional things, you have to still do the show of going every one of the hospitals that are your partners. This is only on network. We haven't even explored to go out of network yet. But in this time, you have to constantly teach, and this is done today, how EMS and the workflow in each hospital it works. We have, the telestroke model, I think, is still here to stay and will help us with coordination of care. But these things, about it. I think what's new is actually we have talked a little bit today on this issue of how important is the most pre-notification you have and knowledge of the case, the severity of the case. You can alert the network to be ready with that ambulance or helicopter in the primary stroke center. So if you know from the field there's going to be an LVO and you have a high degree of certainty that they can bring the patient to the closest center, and that from that center we're already set to go if that center is not ready to do a thrombectomy. So that's kind of that idea of where you go from the field, and the treatment starts beyond the doors of the hospital. So we have many scales. We discussed about this in Chicago. It's very possible that we will have different regions with different scales. So we could not get as a state and coordinate one scale. So we're already seeing that this is happening. FAST-CD in one place, van in another, and different variations in other regions. So there are apps today that you can use basically any scale. So you have every scale there, you pick the scale du jour, and then you use that. So that's, I think, interesting way to coordinate this and without having to buy. And I think it's very similar to the form that you showed, having that little open space for whatever new scale shows up. We have worked a lot. This is a lot of the work with Raul, and but we certainly supported the FAST-CD in the beginning with the ability to determine what score, and actually as you press here, you coordinate that with the communication with the hospital, which is really key, because then it tells you which hospital is closer within your network, and you press there, and it will basically give a Uber type of view to the system. So you can actually deploy your team and be ready to wait for the ambulance as you see that tracking in traffic. But there's a new thing to that. There's a new thought, which is potentially, and this is actually coming out of New York, the Mount Sinai group. They came up with a very clever idea, which I think we're going to probably use too, which is deploy Uber to the tech and radiologist. So the nurse and the technologist and the doctor don't need to drive at 2 o'clock in the morning. So it's a fund that you would actually fund these Ubers to be deployed to the team's house, so that they can then come to the hospital without having to worry about driving in the middle of the night and so forth. But this can be deployed at the same time that you determine that a stroke is going to a certain site. Now, so combination of FAST-CD and joint is crucial, because this is the heart of how do you have the EMS team talking to the hospital as you're in transport. And the communication is really the key here. And the importance of this for me was that not only we're able to have an idea how far you guys are from getting to us, we can share images, but also every element of the code is recorded. And most important, I have to say many times, is that the final outcome, as the EMS team has left the hospital, you actually can see the clot, and you can see how the patient is doing as a feedback that is almost it's basically in the same code that you receive the final part of that. The EMS crew that brought the patient to us can see the outcome of that case. I think this is very important. Now, of course, the timestamps are very much linked to what we need to document. So I think this has a value, and you will see later on for research also. In quality for sure. So this is kind of an idea of all the timestamps, punctured, lesion, first pass, and so forth. And this is now, of course, a key part of, and you can argue you obtain or not CT perfusion, but since we were part of the Dawn trial, we started using rapid, and I think for patients that are beyond the window or within the window for Dawn, we would still do the Dawn protocol at this point using rapid that goes into joint too. Now, what else is going to screening? We haven't talked much about this, but I have to say that I'm looking forward, and I will show some concepts here. This is something that I think Ricardo has discussed before, and I think you have some experience perhaps with this, but the use of not only the scale, but also something else. And it could be transcranial Doppler, could be perhaps, the visor from Cerebrotech, or the CT scan in the ambulance. So where it's going to be, there's going to be a cheap solution, which is a neurological exam, and there's a little bit of an intermediate solution, which is this well, not a CAT scan, but some kind of technology that will help us to screen the patients. But it's becoming very important to not only move with speed, but move with speed and knowledge, and knowing that this patient has a better chance to warn the teams in the hospitals, either you're going to primary stroke or to the comprehensive stroke center, what's coming with a high degree of certainty. And I think your role here will be incredible to be basically very much in connection with the team in the hospital. I think that the ability to share images, and I think you brought up this early, today when you get your phone and you have the image, not only CTA, but CT perfusion there, and this is a new, this is from the Schema View team, they have developed a, also these aspects feature to there. So you have the ability to have all of a sudden in your phone, the whole team is sharing this. So when you have a join app, you link the Rapid to that, you have all of a sudden a CTA, a CT perfusion aspects access to the whole team. And this is really an advancement in terms of speed and interpretation of images. But then it comes down to artificial intelligence and a concept that is really appealing to all of us, I believe. Imagine that if you have on the hospitals that receive the patient first, their CAT scan is being monitored, the images are being screened for an algorithm that can actually interpret that image, and of course it gets better as it does more often and identifies a large vessel occlusion, for example. And if it identifies that, it triggers a response to the team. And this type of message, for example, would be from somebody that is basically getting a CAT scan in a hospital that is connected to your network. And then that image can be shared with the team, and you confirm not only the large vessel occlusion, but also if the brain looks good, and you potentially can do CT perfusion. And in actually, Raul did the first analysis of the Rapid, the ischemia view software, and the Vis-AI for CT perfusion. And I think that, I will let him explain his findings, but I think we have interesting options on this field. And I think it's very important to look into this as how this is going to evolve, who's going to have the best platform. At this point, I'm just, I have to say that this is going to be essential to develop the communication and within our teams, and the growth of this and success would depend a lot of having the combination of this or one platform that runs everything. I think it's important to share AI because it's a concept that I don't know how much of you are familiar with this concept, but this is something that basically allows us to use computers to perform like a cognitive task, which is something, it's a machine learning with time. And it comes into this, what is machine learning, which is it's a branch of artificial intelligence. And I think that this is really important because you have this knowledge driven things that that this is the threshold for the CBF, but then there is the data driven things. You establish a threshold, and that threshold the machine can pick it up on that. So even though the machine may not have the knowledge to interpret what exactly this concept means of irreversible damage of the cells, by using a data threshold, the machine can interpret when that's happening and then link that to the artificial intelligence or this machine learning. It can learn something because it's data driven. And then there is this other thing, which is a refinement of that, which is this deep learning. And deep learning is when you start adding layers to this, and it's just not saying like a yes or no, but it's actually identifying with a more specification what exactly this is with a huge amount of detail. Let me share this with you. So imagine that you have, in our system, and this is how the neuron looks like. You have something like this in the the skeleton of artificial intelligence, all the inputs, and then you start putting weights to the inputs, and that will allow you to get to a decision. Is plus, minus, plus, minus, and it keeps going. The more it uses this algorithm, it gets better and better with time. So it's a little bit of a layer system that we see even in a cerebral cortex. And this is really important because if you look at an example like this is the different layers you're creating, and look at how this works. So you have a little dog, and now you have to say, you ask the system, is this a dog or a cat? And then it will go through a sequence of different nodes into this that will give little weights to this. It has ears, it barks, it eats this, and moves this way. And depending, as the machine analyzes the behavior, it starts to get a higher likelihood to get the right name for it. It's a dog, and less chance to be a cat. And then the more you run this algorithm, it starts to improve the weight of these little nodes, and then it starts to get much faster and more efficiently, to a point that would increase actually the ability to get to that diagnosis, to a point that all of a sudden you are as efficient. You basically, the machine has learned that, and it can give you a degree of information that is much more specific than you could get just by saying we have a large vessel occlusion or not. It can get beyond that. Now, it's very effective as a form of the performance of deep learning for education is huge, and I think it's something we're going to see more and more. Now, look at this example of as you go into this deep learning, how you started by identifying just a blood vessel, but then you can go and start seeing this node here is telling, is it a face or a leg? And then down here, it says, is this a cat or a dog? So depending the amount of layers and that you add to this, you start going from a simple line to then a more specific diagnosis telling exactly what it is. So we talked a little bit about this, how this technology can all of a sudden look at a face and say 94% of chance is this Luke Skywalker. You know, how can you translate characters? You look at a character, or how can it look in this and say it's a chair or person or a skateboard? All these things are incredible, and they're available to us, and they're being applied for the treatment of stroke today. Now, look at this picture. You point here, and you can just by using this technology tell this is a, you can write a text interpreting the image, and this is all done by artificial intelligence. So you basically see the patterns. You can tell that there's a group of people in an outdoor shopping market. You probably look at the sun, look at the vegetables, look at the people, and it kind of concludes all that. This is the one you may be familiar, that you look at the language characters, and it can translate to a language that you like. This is all part of AI. And this is really interesting too, when you look at styles of art, and then you can also analyze the ability to see what kind of style it is, and then say if it's a house in different, if it's impressionist or if it is modern, but it still identifies it's a house. I think this is really fascinating how it does that. You know, if you say if it's a picture or a photo, but it can still interpret the things within that, it takes a lot to get to that. We are there already. So what I wanted to get to is that we are able to identify a dense site. The artery sign is identifiable, and this is now available to you with this technology that allows you to say with a high degree of certainty that there is a blockage of the blood vessel. But then it can also tell you if it is a hemorrhage or just a blockage of a blood vessel. So you can separate intracranial hemorrhage from a large vessel occlusion, which is really fascinating how this can do. This is without neuroradiologists, without anybody else looking at the scan. This is basically just artificial intelligence interpreting that image. And it will go beyond that, aneurysm identification, perhaps maybe other blood vessel abnormalities. So just scanning like this, it's able to tell you all the different types of what is the happening on that picture, because of the more scans it goes through that, and the depth of those layers, it will segment all those vessels and then identify where there is an alteration, a pattern that was expected to have. This is an example with an echocardiogram, and then all of a sudden, if you apply this, you can then identify the different structures in there in a picture that is not that easy to interpret for users that are not familiar with that. And then take a look on this for CT perfusion. One of the problems has been movement of the patient. So one of the things that you're able to do is to correct motion by using this technology too. So you may have a refinement of your CT perfusion maps if you get more patients to have a good picture done, which is a good idea. And I think this is a fantastic thing for EMS. I think it'd be, imagine if you can just point your device to a patient and identify a facial droop. So what the system is doing now is you're able to just pointing your phone or iPad to the patient's face, and it will really see here is following, tracking this just by looking at the patient. Now, all of a sudden, he's going to show a facial droop and lights up as point. This is a point on your scale. So you may not need to do your neurological exam. You may be able to see this happening as artificial intelligence may help you to interpret. And this is a good example of how you do that for the arm. So if you lift the arms, you're okay, you're green. But if you start to get weak, it goes red. So you get a point for that. And then you all of a sudden, you're doing your scale without having to do like a clinical exam, unfortunately, but the reality is that this is possible. This is already on the way. Now, I think it's important for me to bring up that there's a huge challenge. The last 6 months, this is when we put our team together. Was a session of training. So how do you standardize the technique across 12 operators in all these different sites that can potentially do thrombectomy? Is quite challenging. So we have 7 centers that can do intervention. So we started developing, this is actually was our web training. So we certify all the 12 doctors one day, instead of flying everybody to different places. And we brought, Saru came down, Saruhan is here, right there. And then we had a training session. And then, of course, you need to have 3D printing and look at the numbers of the operators and be able to, I think the model that we're gonna be looking at is how do you, the number of cases you need to do clinically and how many you need to do in models to be able to keep your certification, your volumes. That assessment is dynamic, and we're learning how to do that. All right, I promise I'm almost done. This is something that I want to also share with you, that we're very excited about the possibility to move this beyond the pre-hospital screening and in-hospital workflow, but it's basically now giving patients the access to to our health system. So Ricardo and I grew up in a place that basically a patient pick up the phone and it will call. My dad is a neurosurgeon. He'll call. I pick up tons of phone calls in the middle of dinner of like patients calling for a headache or something was going on. I think the access to care is very challenging today. So how about if we start moving, and instead of those apps stopping at pre-hospital screening, now the patients have access to their medical record on their devices. So if you have a system, a network, you have many lives you care for. So you're able to help them to keep on their phones their medical record, and more importantly, their buttons to access your teams in case they have symptoms. And of course, you know where this is going. The next step to this is the wearables. So if you monitor blood pressure, heart rate, and the vital signs of the patient, all of a sudden you can create a pre-stroke or heart attack warning. So you start calling a patient before the event happens. And that is something that we're not quite there, obviously, but is something that I'm very much excited to share with you, that is a project that it has to move forward, because it will allow us to detect this even before the event is happening as we monitor this. So we have some partners that are already doing that. This is a company that does, they have 12 million hours of vital signs with 300,000 patient sessions, which is pretty incredible when you start analyzing this data, how you can detect what happens. So the idea is that you have all these inputs, could be images, could be wearables, and then the patient can see where the hospitals are located. So we have about 76 Walgreens that are affiliated to Advocate Aurora. So you can actually walk into a Walgreens, we have a nurse in there, and then she can get you into the system. So there's like many entry points to the network, but then you have to have the right level of care. And that's why the patient care, the transfer center is kind of responsible to control that, as well as maybe the patient indicating the symptoms, and then we'll know where to go in the closest center that can help them. So all that is moving to how do you collect the data for all this? And this is one of, and I just heard also that Schema View is working with a net for research. So VizRecruit is another way to do this. But as you're acquiring all this data, you also can use that for research. So remember that if your research coordinator and the eligibility and exclusion criteria of the trial are all in place, you can basically start enrolling these patients using this technology too, without having a lot of the communications and things that we do today, and delays quite a bit. So you have a patient, and then you do the CT scan. If he qualifies for a trial, you'll warn the team. And then, of course, the AI can be trained to select based on demographics and imaging if the patient fulfills the trial criteria. Now, this is a horrible picture, but as my last slide, I think, basically, this is Wall Street this week. And the biggest challenge we have is HIPAA. You know, when you start talking about wearables and data management like this, what is today, what is known today of being a HIPAA violation, what is not, and what is a gray area. And I think this is a very good discussion because we don't have yet the control of that. We don't have yet basically a guideline for this in every aspect. So in the green here is when you have a HIPAA issue, which is the doctor communication, whatever the doctor has or the hospital records, or if there's a third party that analyzes for the health insurer, this information cannot be shared around. This is something that is within the HIPAA protection. But there is another area that is patient that share in social media their vital signs or whatever they're sharing, or if they share this with a app that on their phone for exercises or on their watches, these health apps, the patient is giving information to that. What happens with that is beyond HIPAA now because you're allowing that information to happen. The question there is when employers are giving wearables to patients, and are they allowed to monitor those vital signs for their employees? Can healthcare networks do that, or insurance companies? How that works is a little bit of a gray zone yet, but I think definitely an area, as you're seeing where we're going with this, it's going to become more and more relevant for us to be coordinating this for the best outcome of all, and not let this go into, I think it's incredible technology, has to be used in the best way possible. And I think this is what the area that I would see needs to be tightened up a bit more as more people come into this environment. I would like to share, this is a course that Naji is putting together. He asked me to help out in Barcelona for a stroke accreditation. I think we're full already, so maybe it's irrelevant now, but maybe next year. And of course, WNC is coming up May 1st. We are broadcasting from Chicago there, but then you have many other sites broadcasting to Spain. It's going to be a great course. We hope to see you there. If not there, in Washington next year, it will be really great to be part of this. And I have to share with you, Nervous Exchange is growing a lot. And the next module, we invited Eric Peterson to come. We have it all in radio approaches. So it's about an hour and a half of talking from how to start all the way to do complex procedures. And this week, we're filming one on intravascular imaging for new OCTs and mainly focusing OCT for neuro. Thank you so much, Ricardo. This was fantastic. Thank you.